Hello, I'm CarolLucas. I'm going to talk about frontotemporal dementia symptoms and diagnostic methods. Frontotemporal dementia is a common neurocognitive disorder which tends to start in the mid to late 50s and causes rapid decline, with a median survival of 5 to 10 years from diagnosis. Around 40% of cases are familial. The neuropathology involves degeneration in the frontal and temporal lobes with little impact to other brain regions. There are multiple variants. The behavioural variant is the most common, and there are also 3 language variants. For the behavioural variant, we're looking for 3 of 5 behavioural symptom types. They're disinhibition, apathy, loss of empathy, compulsive type behaviours, and hyperorality. For the language variants, we look for a decline in expressive language or inability to find words or loss of comprehension. The individual would likely present with a loss of interest in socialising and self-care. They may be unaware of their inappropriate behaviours, and they've started overeating or chain smoking, and these behaviours are a marked difference from their previous behaviour. Diagnosis will involve a series of neuropsychological tests and imaging analysis. So the pattern of results across neuropsychological tests would be lower performance in tests of inhibition, flexibility and social skills. We may see some impairment in memory and learning, but these won't be the primary symptoms. In fact, Alzheimer's would have the opposite pattern, where memory and learning would be the most affected, social function affected to a lesser degree. Motor impairments may be apparent, but they would tend not to be present early on, and tests of motor function could be used to rule out things like Parkinson's, corticobasal degeneration. I'll now walk you through some of the neuropsychological tests that we use in diagnosis of frontotemporal dementia, looking at how we use testing and imaging in differentiating other disorders as well. So one test we can use to measure mental flexibility is the Wisconsin card sorting task. Here we ask the patient to match a card into one of 4 piles, which might match to colour, number or shape, and they're given feedback on whether their choice is correct or incorrect. The matching strategy becomes apparent quite quickly, and the patient's allowed 6 matches before a response of incorrect is given, and the change in matching strategy is required. Perseverance is indicated here when the patient reverts to the previous matching strategy even after a few correct matches. So this test implicates the prefrontal cortex. It's easy to administer, but once the test is understood, we can't use it again. It'll give us a point in time indicator, but we can't track disease progression with that. A good neuropsychological test for response inhibition is the go-no-go task. The individual here is shown a series of letters, and they press a button each time the letter changes on the screen. After a few responses, a letter will be shown twice in a row, and the individual must inhibit their preponent response on the repeated letter. This tests the inhibition of action, and it implicates the medial frontal cortex. It's an easy test to administer. It can be repeated to give us a view of disease progression. We just need to be aware that complex versions might also engage the working memory, and they won't just simply isolate inhibition. We'd also test for abstract reasoning, for social awareness, for empathy, and we run a series of tests for language skills to identify those language variants of the disease. Again, we'd expect lower results on most of these tests. So memory, learning and motor function should be included in the neuropsychological tests to confirm frontotemporal and to differentiate from other disorders. As I've mentioned, frontotemporal patients may be impacted in these areas, but it won't be their primary symptomology. So degeneration of memory retrieval and associative memory is more typical of Alzheimer's. A working memory test just is not really a good differentiator. tends to be an issue in both of those etiologies. So we're best to focus on the recognition and associative memory. Again, learning might be impacted in frontotemporal, but tends to be more severely impacted in Alzheimer's. And motor function, which implicates the midbrain and the brainstem, would tend to be more indicative of issues like corticobasal degeneration, supranuclear palsy, and Parkinson's. Moving on to neuroimaging tests now. One tool for the diagnosis of frontotemporal dementia is a structural MRI or a CT scan. In the behavioural variant of frontotemporal dementia, we're looking for atrophy in the frontal and temporal lobes in the absence of abnormalities in other brain regions. For the language variants, language subtypes, we've got other specific areas that are implicated for each of those three subtypes. The MRI might not show any structural changes for some cases, and in the early stages of the disease, we might not see any problems. So we would then move on to do a functional scan, either a functional MRI or a PET scan. And here we're looking for hypometabolism, lowered blood perfusion around those frontal and temporal lobes. Again, same regions for the different variants. If we look here, we've got an example of a PET scan for a frontotemporal patient. This is a behavioural variant patient. And we see here the red zones show low glucose metabolism on the PET scan, and they're concentrated in the left temporal lobe. So the fMRI results or PET results, they might be present earlier and in the absence of structural indicators. So we can use this where we have not seen anything on structural MRIs, and we can also use these to track progression. So we can continue to do these tests throughout the course of the disease. So the structural and functional MRIs are also useful to differentiate other etiologies. So in Alzheimer's, we're looking for atrophy or hypermetabolism outside of the frontotemporal regions. And we can also run a specific amyloid PET scan, which will help us identify amyloid plaques that are present in Alzheimer's but not in frontotemporal dementia. Ruling out Lewy body dementia, we'd be more likely to see degeneration in the occipital lobe, and the frontal and temporal lobes might remain relatively intact in that case. And then checking for cerebrovascular dementia, we'd be looking for evidence of events like white matter lesions or infarctions on the MRI or on the fMRI. There's two conditions that can be difficult to rule out during diagnosis, and those are Alzheimer's and a severe form of schizophrenia. So Alzheimer's can be misdiagnosed as frontotemporal dementia. The functional impacts and the speed of progression are very similar. The fMRI results can be similar, and occasionally the amyloid plaques are not apparent in Alzheimer's. So this can result in misdiagnosis. Genetic testing for frontotemporal dementia and Alzheimer's can resolve for some cases, but not all. Also, there are behavioural and anatomical similarities between frontotemporal dementia and a severe form of schizophrenia. The social and organisational symptoms present similarly, and there are occasional frontotemporal patients who do present with hallucinations or psychosis, which is more typical of schizophrenia usually. In most cases, our neuropsychological tests and imaging will give a confident diagnosis in cases of frontotemporal dementia. However, in some cases, we need to consider multiple etiologies that might be more appropriate.